Hi, this is Kyle Claridge, a consultant in cardiovascular medicine in Mayo Clinic, Rochester, Minnesota. And I am very pleased to be here with Dr. Leslie Cooper, who is going to be discussing a fascinating topic about sarcoidosis, what's new in 2025. Dr. Cooper is the Elizabeth C. Lane, PhD, and M. Nadine Zimmerman, PhD, professor of internal medicine at the Mayo Clinic College of Medicine and consultant in the Department of Cardiovascular Medicine at Mayo Clinic, Florida. His career has really focused on the evaluation and management of cardiomyopathies, especially autoimmune variants of myocarditis. He has coordinated the International Giant Cell Myocarditis Registry, the Giant Cell Myocarditis Treatment Trial, and led the international teams on the role of endomyocardial biopsy in cardiovascular diseases for the AHA, ACC, and ESC. He's also been involved in understanding the global burden of myocarditis for the WHO Gates Foundation and has authored over 300 peer-reviewed publications and book chapters. Dr. Cooper has co-founded the Myocarditis Foundation, which is a corporation dedicated to the support of affected families, education, and research in myocarditis. So I think you'll find that he is more than adequately prepared to help us understand sarcoidosis, what's new in 2025, especially as it relates to the cardiomyopathic process. So Leslie, thank you for being here. We're just thrilled to have you discuss this very interesting topic with our viewership.
Kyle, it's great to be with you today, and I'm delighted to share with you the two recent documents, the American Heart Association's 2024 Scientific Statement on the Management of Cardiac Sarcoidosis and the European Society of Cardiology Heart Failure Association and Heart Rhythm Association Expert Consensus Statement on the Management of Cardiac Sarcoid. Most of these, the elements and the recommendations in these two documents align nicely. There are a few differences which I'd like to point out during our interview.
Great. Well, thank you for that. I am, a humble cardiologist, and I think both our cardiology colleagues and our internal medicine colleagues would like just a little bit of background on when should we be thinking about cardiac sarcoidosis in our differential for a patient that presents with symptoms, and how do they present?
Yep. So Kyle, the classic cardiology patient who presents with cardiac sarcoid would be relatively young, younger than you would expect for coronary artery disease, maybe 40s for a male, mid 50s for a woman, but have complete heart block with no other explanation. That would be the classic presentation. Generally, the cardiomyopathy is more subacute or chronic, but the heart rhythm problems present relatively acutely, heart block or sometimes ventricular arrhythmias. The second way that these patients will present to a cardiologist is from referral by a pulmonary colleague who has recently diagnosed mediastinal lymph node or pulmonary sarcoidosis.
So if a pulmonologist sends a patient to us, we should be very alert to that because they've already made the clinical diagnosis of pulmonary sarcoidosis. But if de novo, we see a patient that's relatively young with complete heart block or ventricular arrhythmias, which would be less common, our antenna should go up and we should be thinking about those patients as possibly having sarcoid.
For sure, Kyle. And I'll say the definition or the diagnosis of cardiac sarcoid can be made in two ways. Both the three groups that set out criteria, the Japanese Circulation Society, the World Association on Sarcoidosis and Other Granulomatous Disorders, and the Heart Rhythm Society of the United States, have slightly variant definitions. All of them recognize that a heart biopsy demonstrating the findings of granulomas, which you see in sarcoid, is definite. But many people will not have a biopsy of the heart. They may have a biopsy of the lungs or the lymph node or the skin. In those patients, in the setting of a compatible clinical syndrome or cardiac imaging, that is probable cardiac sarcoid. In contrast to the WASOG and the Heart Rhythm Society criteria, The Japanese 2016 criteria also allow for isolated cardiac sarcoid with no biopsy. In that setting, if a patient has excluded other forms of heart block and serious ventricular arrhythmias, present with compatible nuclear imaging, PET scan, for example, or MRI, and meet other criteria, they could be diagnosed with probable sarcoid as well. That's in the unusual, isolated cardiac sarcoid situation.
And so basically, I'm going to expect that most patients will have pulmonary involvement. What is the percentage that would have isolated cardiac sarcoidosis?
Less than 10% of patients who have cardiac sarcoid proven have isolated cardiac sarcoid. One must always think of other diseases, for example, lymphocytic viral myocarditis or eosinophilic polyangiitis, which presents with asthma and sometimes cardiac involvement, or even Lyme disease, which can cause isolated heart block with a mild cardiomyopathy. Those are all diseases that overlap somewhat clinically.
Okay, wow, that is a lot to think about. I think some almost rare other things that Lyme disease probably not that rare anymore, unfortunately, but a lot of these things are things that we don't think about all the time as cardiologists, correct?
That's true. I think the key to sarcoid is thinking about it. It's not enough to put in the pacemaker or to address an acute issue in a patient who is young and otherwise has no reason for heart block. It is important to go the next step, do the beyond an echo, because an echocardiogram alone is not very sensitive for cardiac sarcoid.
Understood. So what is the testing that you would recommend? So clinically, I have this patient with heart block, just got a pacemaker, and I'm thinking along the lines of cardiac sarcoidosis. Maybe it's one of the ones that hasn't had pulmonary colleagues already diagnosed with sarcoidosis of the lung. What are the tests that you would recommend from a cardiac point of view?
Yep. The pivotal test in the American Heart Association scientific statement is a cardiac MRI with gadolinium. In the European scientific statement, it's an MRI or sometimes a PET scan because you may have a recent pacemaker or ICD that might make the MRI less accurate. But the MRI is the test to think about. In that setting, if you have suspected sarcoid based upon clinical evaluation and an MRI that is completely normal, you have to think, is this very high likelihood or not? If it is high likelihood, go on to the PET scan. That's an FDG PET scan with perfusion. Or if it's low likelihood, you could wait and reevaluate. On the other hand, if the MRI is clearly positive, you do need to know if the inflammation is active. You would want the information from the FDG PET scan to proceed on and advise your patient regarding immunosuppressive therapy.
That's great. So I think, you're really starting to talk about centers with expertise in sarcoidosis and the ability to do a PET scan to tell whether the patient may have active inflammation. And then what would you do at that point in time for developing this multidisciplinary approach? It certainly sounds like that's what we're talking about. So what are the components? Who are our team members, and how do we manage these patients?
Exactly. Central to both documents from the European Society of Cardiology and the American Heart Association is team-based care. You need experts to manage sarcoid who are both clinically adept at heart disease, electrophysiologists, for example, as well as good imagers, and you need experts in immunology. That could be a cardiologist, perhaps with transplant experience, or a rheumatologist who is comfortable using drugs such as methotrexate or azathioprine, which are essential to the first or second stage of therapy. Team-based care is the principle here. Once you get to a definitive pivotal test, such as a PET scan or an MRI, you need to decide two parts. One, what is the arrhythmia risk, and does it reach a threshold where you should consider an MRI, ICD? And secondly, what is the risk of going on to advanced heart failure or future arrhythmia that would be modified by immunosuppressive therapy.
And so what do we do to help prevent cardiac arrhythmias and primary prevention in patients with sarcoidosis, cardiac sarcoidosis?
Great question, Kyle. The people who've had an event, people who've had a ventricular tachycardia or ventricular fibrillation event would, of course, have secondary prevention and warrant an ICD. Patients who have complete heart block related to cardiac sarcoid, there's a 2A indication for a upgrade from a pacemaker alone to an ICD if you're going to be putting in a pacemaker. But then, if patients have preserved LV5, if their EF is less than 35, ICD, but if it's relatively preserved, say a normal or modestly reduced ejection fraction, we look at two other things. First is the burden of scar based upon MRI. Some studies would say greater than about 7% would be clinically meaningful for increased risk. And then the burden of inflammation, which is often associated with decreased perfusion on PET scan. And if you have a lot of inflammation or you have a lot of scar, there's a 2B recommendation to go forward, even if your ejection fraction is 45%.
Okay, let me see if I can summarize this correctly. So if your ejection fraction is less than 35%, it's a 2A indication.
Yes.
For escalation of therapy from a pacemaker to a pacemaker with ICD capability. And then if you have the increased, even if the ejection fraction is not diminished below 35%, and you have a more than or equal to 7% late gadolinium enhancement, that would raise the risk, as well as a high burden of inflammation, and that would be a 2B indication for escalation to ICD capability.
Yes. So yeah, for the imaging based is 2B. If you have if you have extensive, and that is somewhat undefined in the European document, extensive scar based upon delayed enhancement on the MRI, or if you've got extensive inflammation based upon the FDG portion of the PET scan on PET scan. Those would, I would use personally shared decision making with the patient, generally encouraging them to proceed if their ejection fraction is under 50%, but still above 35%.
Okay, great. Thank you for that clarification. So you have a PET scan now that's showing you significant inflammation. What are your first-line immunosuppressive agents that you would be reaching for?
Yes, in both documents from the AHA and the ESC associations, prednisone or corticosteroids are the first-line therapy. In less sick people, oral prednisone, somewhere between 30 and 40 milligrams, would be the initial starting dose with a plan to taper. You could choose only prednisone, or in many practices, we would add a secondary agent such as methotrexate or mycophenolate mofetil at appropriate doses. There's some variability in practice on the first line choice of agents. Other acceptable agents would certainly be azathioprine or leflutamide.
And again, kind of as I hear all of that, it makes me reminisce about how you were really emphasizing the importance of a team-based approach. Someone who has expertise in the immunotherapy, whether that's one of our heart failure experts that deals with transplant, or maybe one of our rheumatology colleagues that deals with a lot of inflammatory processes to manage the drugs, the heart rhythm specialist to help us with the decision-making and shared decision-making around primary prevention of heart rhythm issues, recognizing that there's a gray zone between less than 35%, which we would reach for usually ICD in most patients, and then those patients between 35 and 50, where we would be considering it based on their risk stratification.
Correct.
Great.
And then if the first line of immunosuppressive therapy does not work, you can either substitute for your steroid-sparing agent a different agent. Switching, for example, from methotrexate to mycophenolate mofetil would be an example. Or you could switch to a biologic, such as infliximab, which is a TNF-alpha inhibitor. We use those cautiously in patients with low ejection fractions, but they have been very helpful as they are highly effective at suppressing inflammation, particularly when given with prednisone.
And up until now, I believe we've been talking mostly about those symptomatic patients. Is there a role for immunosuppression in asymptomatic patients?
Great question. So there's not a lot of published data, but there are emerging data on the role on the management of patients who have truly no symptoms. These, for example, would be people who you encounter based upon screening for sarcoid in other organs. If a patient does not require immunosuppression for pulmonary, cutaneous, ocular, neurologic sarcoid, for example, then the decision to proceed with immunosuppression should be based upon shared decision-making. In general, the annual risk for progression to advanced heart failure or a significant arrhythmia is in the single digits, sometimes the low single digits based upon the burden of scar on MRI and the degree of inflammation on PET scan. And so in those patients, some authorities would say it's best to wait and follow them clinically, depending on their risk of opportunistic infection or malignancy from additional immunosuppressive therapy. On the other hand, in patients who have very low risk of malignancy advancing or patients who have low risk of opportunistic infection, you could consider upfront therapy with prednisone or one of the steroid-sparing agents in those patients with no symptoms and a high likelihood of cardiac sarcoid.
Okay, great. Thank you for that. And then I think based on that conversation, I would ask one last question, and that would be the close follow-up. What do we consider kind of routine follow-up of patients that are maybe asymptomatic and then symptomatic with sarcoid?
Yep. So the AHA guideline or scientific statement recommends follow-up with a second PET scan at 4 to 6 months after the initiation of immunosuppressive therapy to assess response to therapy. In those patients who are, and I think that's generally true for the European statement as well, and then over time, I tend in my own practice to space out the PET scans if patients are doing well, often at annual or less intervals if they're doing well. In those patients who are asymptomatic, in whom you choose a watchful waiting approach, those who have been screened and may have no evidence of active disease yet, 1 year has been proposed for repeat screening.
Okay, great. Well, again, a lot of very important information probably could also be reviewed in the scientific statements from both of the societies you mentioned earlier. And I think this has been a really very rich conversation about cardiac sarcoid, which has really advanced exponentially over the years of my career, for sure. What are there any other last minute statements or teaching points you'd like to send home with our audience?
The important thing I would take away from this is to remember to screen. So if you account of those young patients who have complete heart block and you don't have another reason, such as ischemia or Lyme disease, always think about going on to the MRI. And then similarly, in those older patients who may have concomitant coronary disease, but they have atypical aneurysms, say they have a basal septal aneurysm on their echo, which would be very atypical for an ischemic injury. You want to think that there could be in that 55 to 65-year-old range, you're picking up sarcoid in addition to the common atherosclerosis. That's
Great.
all.
Well, that's a very nice summary, and really, I think one of the take-homes for me is just think about it, especially in our patients with unjustified heart block or ventricular arrhythmias. So thank you very much. It's been a great conversation, and we appreciate taking time out of your very busy day to do an interview with the experts.
Great to be with you today, Kyle. Thank you so much.
You're welcome. Have a great day.